Welcome to New York University's School of Global Public Health for this timely panel discussion on police brutality and reform through a public health lens. My name is Dr. LaConte Dill, and I am the Director of Public Health Practice and a Clinical Associate Professor of Social and Behavioral Sciences here at NYU GPH. I am privileged to be your moderator today and to hold space for this important discussion. We have over 500 attendees registered joining us today from across New York City, across the country, and even across the world to examine these issues. And we have assembled an extraordinary group of some of the nation's foremost voices on policing and state-sanctioned violence in order to provide context, their own experiential knowledge, rigorous scholarship, and passionate advocacy to this ongoing national discourse. Please be aware that with over 500 attendees, we have muted everyone except for our speakers so that they can be clearly heard. Thank you to the many attendees who have already submitted your questions. We are grateful to you for engaging in this discussion. Others of you can submit questions in the Q&A tab on Zoom throughout the discussion. This conversation will be recorded and will be made available for those who are unable to join us right now, or for those of you that want to revisit the conversation later. Also, if you want to document your learnings and insight from the conversation on social media, I encourage you to follow at NYU Public Health on Twitter and or use the hashtag reimagine public safety across social media platforms. Now, before we dive into this discussion, I want to invite us all to ground ourselves. I acknowledge that I am zooming in from the traditional ancestral homelands of the Lenape people. I am a guest on this land now known as Brooklyn, New York. We must acknowledge the painful history of genocide and forced removal of indigenous people from their homelands, and we must pay homage and respect to all indigenous people who have been caretakers of this land from time immemorial. We also must pay homage to the people who were stolen from Africa, falsely named as chattel and enslaved, but who have always been fully human. We honor the African ancestors for the still unpaid labor which built what is now known as the Americas. We also all know too well that we are grappling with many losses from COVID-19, while also wrestling with the persistent pandemic of white supremacy and related losses enacted by law enforcement, by vigilantes, and even by healthcare systems and professionals that disproportionately harm, assault, and murder Black, Indigenous, and Latinx people. And in that vein, Breonna Taylor, we say your name. We are so sorry that your neighbor's walls received justice before you did. And at this time, I just invite all of us to take a moment for all of the names that we know that have been hashtagged and amplified, and for all the names that we don't know and that have been erased. As we have these conversations today, I encourage you all to check in with yourself, your body, your breath. Feel your feelings, allow your rage. I'm thinking of Audre Lorde and James Baldwin, who have written and given us permission and instructions to do so. Allow your sadness, your fatigue. Breathe deeply into those tensions. Take a sip of water. These conversations might also inspire you. They might give you hope. They might provide some direction. Feel those feelings too. Snap your fingers and give head nods. I'm sure our speakers will feel that energy even throughout Zoom. May we all commit to continued struggle for liberation and justice. Now, please join me in welcoming our guest panelists. I will share their very brief versions of their bios that are very rich in the interest of time and in the hope that we will get to know more about their backgrounds and their standpoints as they continue to share with us. Dr. Hannah Cooper is the first Rollins Chair of Substance Use Disorders at Emory University and a professor of Behavioral, Social, and Health Education Sciences at the Rollins School of Public Health at Emory. Of note, in January this year, Dr. Cooper and her colleague, Dr. Mindy Fulilove, published the book From Enforcers to Guardians, a public health primer on ending police violence. Dr. Alyasah A. Sewell is an associate professor of sociology at Emory University and founder and director of the Race and Policing Project. Dr. Sewell is widely published and widely funded by sociological, public health, and interdisciplinary sources. Of note, Planned Parenthood named them the future, innovator and visionary who will transform Black communities. Ashe. David Norman is a research assistant and committee advisor to the Incarceration and Public Health Action Network, IPHAN, at the Mailman School of Public Health at Columbia University. IPHAN seeks to build a national effort to examine mass incarceration through a public health lens. David is a researcher, community educator, motivational speaker, social justice advocate, and a proud Harlemite. Kanwarpal Dhaliwal is the founder and associate director at the RYSE Youth Center in Richmond, California, and is adjunct faculty at San Francisco State University. Kanwarpal centers healing, racial justice, and liberation across RYSE's programming and across the fields and sectors in which RYSE and the youth there work. Without further delay, please welcome our first speaker, Dr. Hannah Cooper, who will provide us with a deeper understanding of police violence and its impact on population health. Dr. Cooper.
LaConte, thank you so much for that, that really wonderful and moving opening. I'm really honored to be here today. This is a tragic day, like honestly, so many days before. And I'm grateful to be able to spend some of it with the other panelists and also with all of you. I'm going to be spending the next 10 minutes with you discussing the nature of police violence and discussing what we know about its health impacts. Know that David Norman will be speaking about vital elements of the history of racialized police violence in this country in a bit, so know that that's coming. Before I begin, I need to raise up a couple of things. So first, police violence, and I think LaConte discussed this quite just remarkably well, that police violence is not something that just happens to other people out there. It's a form of state-sponsored terrorism that happens to people that we love. It may have happened to some of you. And it may be something that you worry about every time you or someone that you love leaves home. I think it's important to recognize that personal dimension of this state-sponsored terror and also make sure that you know that if you need to mute us or step away from the presentation, you should do whatever you need to do to take care of yourself. I also need to report a conflict of interest. So I identify as non-Hispanic white. And I'm descended from people who enslaved other people, both in New York State and also in Virginia. And the painting that you see here is of a great-great-grandmother of mine in upstate New York. And in the back is a man named Mr. Joseph Stewart. Mr. Stewart was one of many people that my family enslaved, though he later freed himself. That heritage, along with present-day manifestations of white supremacy, they've given me, I think, a wealth and a power that have been forcibly stolen from other people. One of the implications of this is that, try as I might to engage in anti-racist work, I still have a vested interest in maintaining white supremacy. I'll have to relinquish wealth and power in order to end it. And so I caution you just to listen to me today with some skepticism. Ask yourself about what I might be unable or unwilling to recognize or understand, and think about how white supremacy and the ways that I benefit from it might limit or distort my perspective and my remarks. So my charge today is to start framing police violence as a public health issue, in addition, of course, to having it be a human rights or a civil rights issue. The Surgeon General declared violence a public health issue in the 1979 Healthy People Report. And our field has been actively involved in surveying and intervening in violence ever since. We have developed surveillance systems for child maltreatment and for civilian on civilian violence and homicide. We have mountains of data on who is affected by different forms of interpersonal violence and on the immediate and chronic effects of child maltreatment, intimate partner violence, and community violence. And we have developed community-level interventions to prevent and intervene in these forms of suffering. Police brutality, of course, can be understood as simply yet another form of violence, though here perpetuated by the state. And that, of course, would fall in our purview. As so many other kinds of violence do. And it's a form of violence that we all know is remarkably common, and yet public health has neglected it for decades while we sought to intervene in other forms of violence. And to me, this neglect means that we, in public health, are somewhat culpable for its perpetuation, right? I think we need to answer for that as a discipline and as a profession. We know from non-governmental sources, because our public health surveillance systems are failing us, we know from non-governmental sources that track police violence that over 1,000 people were killed by the police in the US in 2019 alone. That's about on par to prior years for which we have data. And I want to put these numbers in perspective for a moment. 1,500 people have been sentenced to death and executed in this country since 1976. Right, so decades and decades. These executions, they occur only after the individual has been tried and convicted by a jury, has been sentenced to death, and has typically filed and lost multiple appeals across years, sometimes across decades. These executions are often preceded by international vocal protests. In contrast, when a police officer kills an individual on the street or in their homes, they bypass the system altogether, serving as judge, jury, and executioner of a potentially innocent civilian. So these killings sidestep our entire judicial system. Horrifying as these killings are, I want to take a moment to widen out our lens here and recognize that police violence extends far beyond these killings to include multiple other forms of violence and public health harm. So, and here I'm going to use some data by a study by Jordan DeWilder, who asked people living in 4 cities about their experiences with police violence in 2016, and then I think he returned in 2017 or 18. The 4 cities, of course, include New York City, and then also Baltimore, Philadelphia, and DC. Jordan's measure was pulled from a study that I had taken part in the Bronx in the 46th precinct. People in that community had talked a lot, quite extensively, about their experiences with police violence, and those stories actually mapped onto WHO's definitions of violence. And let me describe those 4 categories. So the first is neglectful police violence, in which police don't respond at all, or they respond too late, or they respond inappropriately when an individual calls for help. Another type is physical police violence, in which police use some kind of physical force with an individual that can include hitting, punching, kicking, dragging, or beating them. Psychological violence is when police use non-physical aggression with an individual, including cursing, slurs based on their race, their ethnicity, their sexual orientation, when they use threats, when they use intimidation. This includes also stops and frisks, relentless stops and frisks, as we have seen in New York. Sexual police violence is the final form of violence, and this is when police force sexual contact with an individual, and this includes searching people's genitals, particularly in public spaces. So DeWilder used these definitions to create a survey of police violence, and also importantly, he added a measure of positive police encounters, and he surveyed hundreds of people living in these 4 cities. And as I talk about these results, know that I'm pulling this slide and some of the others from a wonderful scholar named Leslie Salas Hernandez. As you can see from Leslie's slide, this is what Dhaliwal found across the sample. So the most common forms of violence are neglectful police violence and psychological police violence, with about 18 to 19% of respondents reporting direct in-person lifetime exposure to this kind of violence. About 6% of people reported experiencing police physical violence without a weapon, and 3% reported experiencing police physical violence with a weapon. Another 3% reported experiencing sexual violence from the police in their lifetimes. As you might expect, given the racialized history of violence and the purpose that it serves in perpetuating white supremacy, there's a lot of heterogeneity across subpopulations and exposure to these different kinds of violence. When we look at gender, we see that people who are trans experience more violence than any other group, followed by men. Trans people are also less likely to report any positive experiences with the police during their lifetimes. Shifting to age, people who are 25 to 44 report more experiences with violence than any other age groups by and large, but they also experience more positive encounters. If you look across racial ethnic groups, you see that non-Hispanic white people experience the very lowest forms of all kinds of police violence, as do straight people. There are differences by income, as you can see here. So a few conclusions from this important work. While deaths are relatively rare, though catastrophic events, other forms of police violence are relatively common. There's also considerable heterogeneity within populations in their experiences of police violence, with structurally marginalized populations reporting the most violence. And this is what you would expect given the role of police in US society in terms of creating and perpetuating marginalization. These slides, so I think important as they are, they underplay the full scope of the health impacts of police violence, and they do that in 2 ways. So first, they focus on the targeted individual, and second, they fail to capture the long-term effects of police violence. But we know from decades of research on intimate partner violence and on other forms of violence that violence itself ripples across communities and also across the life course. And I want to bring that those important ideas into focus for a moment. One of the most powerful studies about community-level long-term effects of police violence was conducted by Bohr and his colleagues, including David Williams. Bohr studied the mental health effects of a police killing of an unarmed Black man in one state. And they found that in the year after such a killing occurred, Black people living in that state suffered more mental health problems. The effects were worse, or they were the most acute in the first 2 months after the killing. Very few of these affected people could personally have known the victim or could have witnessed the event. This is state-level data. What's important about Bohr's work is that they established that simply knowing that the killing had happened in one state was enough to erode mental health. Tellingly, there were no effects on white people's mental health, which I think is an indication of how white supremacy damages white people's capacity to empathize and to live fully in this world. Dr. Sewell at Emory has done some very important work on the effects of police violence on physical health and thinking about kind of long-term health consequences of exposure to police violence. Normally I would describe their work here, but Dr. Sewell is with us here today, so you don't have to listen to me try to kind of muddle my way through. I'll just say now that their work has generated much needed public health evidence about the ripple effects of police violence across communities and across lifetimes. And so I'm going to turn this over now to Dr. Sewell.
Hey, how are y'all doing? It's good to be here. So what I'll talk to you about today is what I call the negative illness feedbacks of policing. I'll focus on the psychological and the physical antecedents, and I'll talk a little bit about the healthcare parts of this as well, which what I believe is what starts this feedback process. So it's one thing to be sick and one thing to be exposed to risk factors that make you feel sick. There's another thing to not have the resources to deal with that sickness because of the same factors that influence the utilization process and the availability of care possibilities within an environment. So the data that I look at is New York City. We do some work in Philadelphia as well. I look at essentially what they call stop, question, and frisk policies. They have various different names across the nation. But what we're talking about essentially is you're on the street or you're in a car and there's a likelihood that a police will stop you because you either look suspicious, engage in suspicious behavior, or you fit the description of someone who does. What we find in New York City is that there's actually a lot of variation in where these stop, question, and frisk policies are enforced. So on average, there are about 30 stops per 100 residents in New York City, which is quite high. Essentially, you have a 1 in 3 possibility of being stopped. Among those who are stopped, there is about 55% of those stops involve some type of pat down. So this is very light touches on the body. Once you get to more aggressive touches on the body and even the use of some type of physical restraint or weapon, that happens to about 1/5 of those who are stopped. There are also racial differences in the likelihood of those things happening stop the experience of frisking and use of force. What we know is that when you look at Black and brown residents or Black and brown pedestrians of New York City, these could be people who live in those neighborhoods as well as people who are passing through. That Black and brown pedestrians in New York City are 6 times more likely to be stopped. 6 times more likely to be stopped. They have a greater chance of frisking by 25%, and they have an increased risk of having use of force against them by the police by 28%. We take these measures and essentially codify them at the neighborhood level, and we use that as a characteristic of the place that someone lives in, and we understand essentially what is the reports or risk of reporting psychological distress, underlying conditions, these physical and general health problems, if you live in a neighborhood where these types of stop patterns and frisk patterns occur. What we know from this type of data is that in general, we can count it as a kind of what is a standard deviation increase. So we're looking at percentage points. So for instance, for frisking and use of force, you're looking at a neighborhood that on average has 54% of those frisks, and you're comparing it to a neighborhood that has 63% of frisk. And similarly with use of force, we have a neighborhood that has 21% of use of force, and we're comparing it to a neighborhood that has 30%. So these numbers look fairly small when you think about them, but however, when you consider the full scale of this, we're talking about a fairly common experience of stop, question, and frisk for some of these neighborhoods, whereas in other neighborhoods that are essentially protected from these forms of violence, stop, question, and frisk is less likely to be prevalent in those spaces. What I find first is when we look at psychological distress, we're looking at what we consider a set of feelings that indicate some kind of clinical measure of psychological stress, meaning that you could at some point of time be identified as experiencing a diagnosable mental illness or some other type of disorder. What we know is that if you live in a neighborhood where there's a lot of frisking, again, that 9 percentage point increase in the pat down, that there's a higher likelihood that you experience some form of non-specific psychological distress at a clinical level. So there's within the month, you're experiencing sometimes or all the time. We also know when we look specifically at use of force, we actually see a different pattern. There's less indicators of sadness. There are less indicators of feeling like everything is an effort. And so we have to think about what that means. What we do in this study, this is one of the first papers that were published on this type of data, is we look at we split the risk of experiencing psychological stress by whether you are a male identified or female identified in the survey. What we know is when we compare the risk within the same neighborhood, so then we're looking at that neighborhood, for instance, that has 63% of the pedestrians having use of frisking against them, versus neighborhoods where it's only 54%. In those neighborhoods, the comparison between men and women in those aggressively surveilled, proactively surveilled neighborhoods, men are 21% more likely to experience some form of clinical, non-specific psychological stress. They're 14% more likely to say that they're nervous, about 13% more likely to say that everything all the time within is an effort, and they're 18% more likely to indicate they're worthless. I think there's a way to think about this at a more meta level, that I am emotionally disturbed by policing, but then these feeling states, being nervous, feeling like everything is an effort, feeling like I'm worth it. These are particular types of feeling states that are produced from these I would say abusive interactions with the police. You don't feel like you are in some sense worthy of getting that nod, of being considered not a threat. You can stay on that, the 10 blocks that you're trying to walk to school or to a healthcare system that it takes a lot of effort. You have to do a lot of things to avoid being stopped. And of course, you may be running out of time. And so it's in your interest, essentially, to look like you are not engaged in criminal behavior. Some people, however, can never escape that. And this is kind of what are the things we're looking at. We also understand that these types of stop patterns and the most persistent and consistent indicator of higher reports of underlying conditions is the pat down. So in neighborhoods where there's an increase of risk of being pat down, there's also higher reports of every indicator of underlying conditions. All of these underlying conditions are also implicated in a coronavirus pandemic. You would think that there should be no relationship to what is happening 10 years ago. These are 3 or 4 years prior to the fall of Stop, Question, Frisk in New York City. And now we're talking about a coronavirus. This is the last year. There should be no relationship between diabetes and frisking. There should be no relationship between high blood pressure and frisking. There should be no relationship between asthma and frisking. There should be no relationship between being conceived as overweight or obese and frisking, right? These same relationships shouldn't persist across time. But what I argue here is that the policing inequities creates a system of social relationships that are disruptive, not just to the mind, but also to the body. And those types of systems are also present in the same things that indicate that we are actually at higher risk, 2.4 times increase in the risk of death due to coronavirus for minority communities. And if you look among those who are more likely to die of coronavirus, these are the conditions: diabetes, high blood pressure, asthma, being overweight. These are the same conditions that are implicated in severe coronavirus conditions. We also know that there are racial differences within the same neighborhoods. Again, we're looking at these neighborhoods where there's maybe a 9 or 10% increase in frisking or use of force, where you go from having a kind of average levels of stop and frisk to maybe 8 or 9 of these stops and frisks per person for each person. We have the situation where Blacks are more likely than their white counterparts in the neighborhood to have a higher risk of blood pressure if they live in high stop rate neighborhoods and neighborhoods where there's a lot of racial disparities in use of force. So this would be the conversation I was having before about the 25% increase of frisking among a minority community, minorities than among whites in the same community, by the way. Among Latinos, you also have higher risk of blood pressure. These are in high frisk neighborhoods and high use of force neighborhoods, and even Asian Pacific Islanders. And this is really important because Asian Pacific Islanders are less likely to be stopped by the police. They're also less likely to have health problems. However, if Asian Pacific Islanders live in a neighborhood where there's a lot of racial disparities in use of force, they in fact report their health as less and poorer fare. The reason why this is important regarding self-rated health, again, this is also something that was indicated in the underlying conditions models. What we find here is that worse self-rated health is actually very strongly linked to early mortality. So what we're mapping here is these long-term trends, not just feeling bad, not just feeling as if your body is compromised, but also increasing the risk of death for people who live in these inequitably surveilled neighborhoods. I'll just show a couple more slides. I know we're running short on time, but essentially there's 2 types of ways to think about the effects of racially marginalized spaces. On one hand, in places where there are more minorities and in there, these are Blacks and Latinos compared to whites, in areas where there's more use of force, that the risk of diabetes, obesity, high blood pressure go up. This is interesting in some sense because these are neighborhoods that are under assault for many different things. They're poor neighborhoods, they're neighborhoods where there's less wealth, less access to quality education, and policing social relationships that are established between people who use those spaces and people who are moving through those spaces, that there is also a risk that is uniquely tied to the policing systems. On the other hand, in neighborhoods where there are not many minorities, these are not many Black and white people, you also see higher rates of illness, diabetes, obesity, high blood pressure, and even worse self-rated health in predominantly white communities. So again, we have this paradox: Asian Pacific Islanders less healthy, as well as less likely to be stopped. And again, this is the same situation, predominantly white neighborhoods where there's less stops, as well as a healthier population in those neighborhoods where that's happening. If they're in a neighborhood where use of force is primarily targeted to Black and brown people, that whites in those neighborhoods, basically, they suffer more. So this is not a Black and brown problem. This is not a racially segregated problem. This is a society problem, and it's our interest to look at it this way. There was a paper released in this last summer. We looked at, within the 10 years of the fall of stop, question, and frisk, neighborhoods where there were 3 or more lethal contacts by the police. So these are 3 or more killings. These are identified by medical examiners and coroners as the police did it. There's no other way. It didn't happen unless the police was involved. We find that there's a greater risk of high blood pressure and obesity in these neighborhoods. Among women, there's a greater risk of obesity. And unfortunately, when you compare women to men, there's evidence of a trifecta. Women, compared to their male counterparts, have a greater risk of diabetes, high blood pressure, and obesity. Again, this is the CVD trifecta, and this is more likely to be present among people who live in these neighborhoods where police killings are more likely to occur. Lastly, when I talk about this negative illness effects, let's say we have all these problems. We would assume that if you have all these problems, you're going to need to go to the doctor. Though what happens, however, that if you actually say that your health is worse, is poor or fair, the likelihood of being able to go to the emergency room, this is mean you have a problem right now and you need to deal with it, is actually less if you live in a neighborhood where there's higher rates of frisking. These are included pedestrian stops as well as vehicular stops. So I'll stop there, and all I will make here is the pitch that policing is really the blood of America. We can look at these different structures of where people live as patterned by segregation. We can look at what we see right now across the nation, whether it's George Floyd or it's Eric Garner or it's Breonna Taylor. People are mobilizing to deal with this issue, this problem, this social problem of policing. All of these structures sit at the middle of them is the blood, it is the illness, the body, the impact of these larger inequitable systems on the body. However, I will make this argument, and I'm pretty sure there's a lot of evidence that is accumulating for this, that the surveillance structures that we're in is a key mechanism that creates this entire systemic oppression that people are under. I'll stop there.
Thank you, Dr. Cooper and Dr. Sewell. Now we'll have David Norman, who will continue to discuss police brutality, violence, and traumatization through the lens of his own personal story. Mr. Norman. Unmute yourself.
I said, hello, and how's everyone doing? I hope you're all doing fine out there. I want to look at police brutality in a wider, through a wider lens, because I see police brutality as racialized oppression manifested in acts of violence and targeting particular social groups. And as such, I think brutality, police brutality is symptomatic of a larger problem, you know, and when I talk about that problem, I'm talking about oppression in general. And there are many subcategories under oppression: racism, ableism, ageism, etc. And so this is going to be, I'm going to do a very short explication of 3 periods in history in the African-American experience. That's slavery, Jim Crow, and mass incarceration. And what I'm doing is trying to show a relationship between trauma in those 3 periods. But I also have a personal story to tell, so I'm going to make this very brief. So starting with slavery, I want to talk about sexual violence. Sexual violence like rapes, child molestations, and mainly amongst women. That's not that men weren't sexually molested or victims of sexual violence. It's just that women have more exposure to trauma, and women have higher rates of PTSD. They not only have higher rates of PTSD, their rates of PTSD behind sexual violence is, well, not behind sexual violence, their rates in general are twofold that of men. Many traumatologists think that this is the result of sexual violence. And sexual violence is one of the, and when you talk about trauma and recovery, sexual violence needs like more work in order to recover than a lot of other types of violence. So I want to move past slavery very quickly to Jim Crow. During the Jim Crow period, there were two types of violence that I find to be very, very prevalent. One was domestic terrorism in the form of vigilantism and through the guise of white supremacist groups like the Ku Klux Klan. The second type of violence, if you can compare violence, and I'm not sure you're supposed to do this, but I would have to say that the second type of violence, lynching, it was even more odious and horrific than the domestic violence because it was double-barreled. It was double-barreled in the sense that there existed two purposes for this violence. One was to negate Black bodies. One was to take the life of Black people. And the other purpose was to traumatize people. Often in lynching, the bodies were left hanging, or if they were beaten and mutilated, left in the streets so that the Black populace, as it went about its daily business, had to look upon these bodies. Traumatologists call this vicarious trauma. We still see it today with police brutality. I want to now move to the period of mass incarceration. And Jim Crow lasted approximately 100 years, according to some scholars, actually up to 1968. The reason Jim Crow actually was curtailed was because of the successes of the civil rights movement. And when the civil rights movement was successful, it made it unpopular to be an overt racist. You couldn't say the things you used to say. So they used terms like colorblind and other terms whereby they tried to suppress racist tendencies. But there was a white backlash, and of course, that backlash led to what we now know as the war on drugs, and which I call it an illusory war on drugs, because the purpose of the war on drugs was not to deal with drugs, but was to deal with to racially control and socially control Black people. So I don't have to say much about this because this is going on right now. We've seen George Floyd, we've seen all of the people over the last few months that are now being videotaped, and we see it on videotape and we see what's happening. What I will say is it also has a traumatizing effect on individuals, especially, again, vicarious trauma. The people who have to witness this. If you look at the George Floyd incident, you see people standing around, you hear people saying, man, you're killing him, you know, and this is trauma. And whoever has just heard me probably said he speaks a lot about trauma. So if you have a suspicion about trauma and me, you're probably right. I am a child of trauma. At the age of 5, my mother was incarcerated. Shortly thereafter, my father followed suit. My grandmother, who was raising me, thought it would be a good idea to ship me off to a sister who lived in the suburbs of Westchester County, the suburbs of New York. Middle-class Black woman, home, husband, car in the 1950s. But within 2 weeks of the time I got to live with her, I was being beaten and smothered. That went on for 5 years in my life. I ran away at the age of 10 and came back to my grandmother's house in Harlem, where I grew up. And I told her what was happening. She said to me, my sister wouldn't do that. And she tucked me back. Fortunately, 3 days later, and I'll never forget this, because I was standing in the living room when she said this to her sister. She showed back up and she said, that boy has never lied to me. Get his clothes, I'm taking him with me. And I will always remember that moment at 10 years old. Now, I was returned, I went back to Harlem, things were well, right? Everything was good. Well, that's not true. If this was a Hollywood movie, you know, we'd have a happy ending, but it's not. The people out there who understand trauma, ACEs, adverse childhood experiences, understand that the story had just began. By the time I was 10 years old, I was drinking. I was picking up the drinks in my family's house and drinking them down whenever they had visitors and they sat around and they had parties. I would drain the glasses. By the time I was 13, I was sniffing heroin. By the time I was 14, I was selling heroin. By the time I was 15, I had stabbed 2 people. By the time I was 18, I was sitting in a New York State prison on charges of possession and sale of a controlled substance. After doing that bid, for the next 30 years, I had 12 more arrests. I had 4 or 5 city and county incarcerations. And at the age of 47, I was locked up again for homicide in the 2nd degree. They broke it down to manslaughter. It was a street fight. They broke it down to manslaughter, and I did 4 to 12 years. But something happened during that particular bid. I really began to realize that I didn't want to live this way anymore. I wasn't sure what to do about it, so I do what I do with almost every problem I have. I grab a bunch of books and start reading. I had 6 years to read, so I read everything that I could. I even started to practice a certain type of cognitive behavioral therapy on myself to change my thought patterns, because I thought it was very much about the way I thought. And that worked. It actually worked. I mean, it's called rational emotive behavior therapy. But I came home. I got a job at a hospital in Westchester County as an outreach worker. During a conference that I had to go to as an outreach worker, I met a gentleman from Columbia University. He asked me, did I want a job at Columbia University on a part-time basis? I said, sure. I took the job, and I had the job for 2 years. And then the 3rd year, the full-time position opened up, and I took that job. That gave me entree to Columbia University. I didn't have to pay tuition. The problem was, could I get in? I took a test, and they let me in. I spent 10 years working on this degree because I could only take 1 or 2 courses per semester. I graduated 4 years ago at the age of 67 with a degree in philosophy. But that was the happiest day in my life, I think, up until that point. But it wasn't the most important day in my life. I talk very often about my situation, and in talking about it, I was doing therapeutic work. I didn't know that. But what happened was I was talking about it in a class, and as I left the class, a young white gentleman about the age of 19, somewhere between 19 and 21, tapped me on my back, and he said to me, you know you've been traumatized. And I looked at him and I laughed, and I said, of course I know I've been traumatized. And he laughed and he went his way and I went my way. But as I was walking down that hallway, I realized that I didn't know I had been traumatized. I had read about trauma. I knew the name of trauma. I knew what traumatization was, but I didn't realize that it applied to me. That was the sad situation. I didn't know what impact trauma had on my life. So I started to read everything I could about trauma, as I want to do with my particular problems. But I also took a post-baccalaureate classes given by the University of Buffalo Social Work School, which is a very good institution. And I took 8 classes and I got a certificate in online clinical foundations of trauma. And that sort of changed my life because I began to understand how trauma really worked. And so what I did after that was I got a therapist. That also has changed my life because I'm not only there just for the therapy, I'm there also to kick ideas around with the therapist. And she does that with me. And she lets me, and she explains theory to me. I explain the stuff I've read to her. And I think we learn from each other. And so my life has changed just because of that. But what I wanted to say in the end is what I learned is that there are 2 types of pains. There is physical pain. When you have a broken limb or a broken leg, what do? You get off of the limb, you don't walk on it, you are on crutches so you don't destroy the limb any further. If it's an arm, you're in a sling, you want to immobilize it. That's what people attempt to do with trauma. Unfortunately, emotional pain works exactly the opposite. You have to process it. You'll hear therapists say you have to work through it. The problem with traumatized people is that they often don't try to work through it. It is painful to work through it. And they have to be in a safe space to work through it, because then they'll relive the trauma. So what we do is wall it off, or as Freud would say, repress it. But I started to work through my trauma, and I have worked through my trauma. So this is what I will say to you. I've told you two stories. I've told you a story about the trajectory of my life, and I've also told you a story about the trajectory of the life of a collective known as African Americans. The problem is that African Americans are suffering because their lived experience is denied. You can't work through trauma when people are denying that you actually had that trauma. When people ask you, when you talk about slavery, why are you talking about slavery? If people don't understand that slavery can have an impact on people today, there's a saying we use: the past is in the present. And one of the things you have to do with a cultural trauma or collective trauma is heal history. It's not only about the individual, it's about the collective as a whole, healing history and narrating meaningful stories, telling your own story in your own language so that you can have meaning in your life about exactly what happened to you. This is how you create healthy ways of dealing with your trauma. Until that, and what's happening now is like people are denying trauma. And so until the generations of the enslaved and the generations of the enslavers sit down and acknowledge that there's a problem first, and then ask each other across the table, what can I do to help you heal? And and because perpetrators need healing also. And so until that happens, we will have this mess that we now have in terms of the divisions in this country. And you can't go on denying the existential factors of people when they're crying out for help. Thank you.
Thank you so much, David. So many people are chiming in the chat that they are also thankful for you for sharing your own personal histories of trauma, our collective, vicarious, and chronic trauma. I think sometimes public health is late to understanding trauma and even applying trauma-informed strategies, let alone healing-centered strategies. And you really moved us at the end to think about truth and reconciliation, right? And I think that's a great segue for our last but definitely not least presenter. Kanwarpal Dhaliwal is going to discuss how public health and adjacent systems over surveil Black and other minoritized communities. And she will provide some strategies, call us to task, call us in, strategies for reckoning, for liberation, for justice. Ms. Dhaliwal.
Thank you. I have to say, I feel really moved by being in this beloved space. And I realized I was trying to contort my screen and even my presentation to kind of fit into what honestly white supremacy needs us to fit into, even though I'm going to talk about how we need to not, we need to get whiteness out of our systems. And I just really want to thank all of you for holding the space to be in pain, to be enraged, to be so clear. Yeah, I know I was a last minute invite, and I'm just like, this the universe provides. So I feel like it's really important to say that here. And I also moved my screen because I come here, I'm speaking to you from Ohlone land. I am a first generation first born in the US to South Asian immigrants. So I'm here kind of on the both being cradled and caught from occupational to neoliberal colonialism and empire building for this country. And, you know, what we are taught and conditioned as South Asian immigrants is that, you know, our proximity to whiteness is what's our success. And our distance from Blackness is what's our success. And so I hold that, and I want to acknowledge that. And I also want to acknowledge I've grown up with all my material needs met. I never worried about housing, about food, about clothing. And I also grew up in direct racial violence and domestic violence. And I'm actually talking to you from the room I grew up in as a kid, and just really feeling like what it means to be here in this space with you all, in a room that has so much history of danger. So all of that is happening, and I share that because all of us are coming into that space with all of it. And if there's anything I can say or I would want folks to remember is we have to complicate, texturize, complicate our work, that we come with all our subjectivities, all our places of protection and privilege, all our places of subjugation. And that really is the work and the world that I work for, and I'm humbled to be a part of a community and organization that works for that. So that said, I'm gonna share screen. So I'm with the RYSE Youth Center in Richmond, California. I could tell you a lot about RYSE, but we also have a website. I feel like it's not hard to go there, but we provide a lot of different supports and programs for and with young people. We were born out of Black and brown young people organizing to shift conditions of acute, constant, and structural violence in our communities. And it was young people, Black and brown young people, 15, 16, 17-year-olds, thinking about legacy, creating something they wanted for 5, 6, 7, 8-year-olds. They built RYSE knowing they would never directly benefit from the programs and services. So young people, the most structurally vulnerable young people, thinking about legacy and what their responsibility and work is for the next generation. And it's on their shoulders and their risks and their labor that I'm here. And so I want to start by sharing some of the truths of our young people. And these are direct quotes. Realizing institutions don't work for you, but against you is the first step to healing your community. We know we can't run the city, it's too complex, but our experience and our voices should count, especially because we're the most affected. My experience with violence is very brutal. I grew up with violence as if it were my sibling. Healing looks like education. If people understood their privilege and how their actions can deeply affect someone, I think it would help a lot of people who are struggling with these issues. So for young people in our community, what they are continuously willing to share with us is that the connection and intimacy to violence is constant. The need and want for healing, relationship, and to actually name the conditions of violence is also constant. For us as an organization that provides direct services, we get money to do violence intervention, violence prevention. What we have to really understand is that violence, because we live in a country that relies on violence, violence is the engine, not the exception. It is the pattern, not the outlier. That we have to actually show up for so many young people who talk about the one moment they felt they were in some control was when they enacted some harm. And the one moment they felt most traumatized in their lives was when they enacted harm. And how then do we hold young people with unconditional love in both those places and spaces? It is not enough to say, you need to get away from so-and-so to be able to sort of stop these behaviors. So I just want to, again, complicate what's going on for young folks. And again, I feel like I'm following in really sort of legendary work and amazing work of the previous panelists. And I think I'm not going to share anything necessarily new, but I want to share really what we understand from our lived practice as an organization, a racial justice organization. a healing-centered organization, and we consider ourselves a public health organization. And in that, Black and minoritized communities are policed by all systems. Certainly law enforcement, certainly the police, but we would also say our educational systems, our public health systems, we police through our pathologizing. That young people actually feel the distress no matter what systems they're engaged in. So they are always prepared for the threat, whether it's at school, whether it's at the doctor, whether it's seeing a police car come down the street. So for us, we have to, as an organization, hold all of that, meet young people where they are, and also work with these systems. So we are proximate to our young people, and we are proximate to the systems responsible for them. And I think about, in this context of reimagining, defunding, certainly abolition, how do we also understand that it's not enough just to say we need more mental health supports for young people, because the existing mental health supports are actually not designed to support Black and minoritized communities. There is actually even more harm. We as an organization struggle with referring young people to other places because our caseloads are full. And when we do, I will tell you this, over half the time, our young people come back and get mad at us saying, why did you send me there? They don't know how to help me. They don't give a shit. I think at the same time we talk about Black and minoritized communities, we also know that the systems are also actively ignored and absolved of the brutality and dehumanization of the dominant. So we're really good at looking at ourselves as the problem, right? Like if we have this incessant focus on Black folks, brown folks, queer folks, poor folks, we get to ignore the systems of whiteness and supremacy, and the surveillance on them it just doesn't happen. And so we continue to sort of reiterate and calcify the problem as us. What we also know is that all the ways in which we're set up to and encouraged to and forced to comply with white supremacy, for us, you know, as a nonprofit organization, we have to report to funders, to policymakers, and there's all these metrics, right, and outcomes. And we really understand them as metrics of compliance to white supremacy, to racialized capitalism. You know, and more we're seeing as sort of the trauma train is in the world now of public health, child welfare, even juvenile systems and criminal systems. This idea of resilience, that, you know, RFPs come out to increase the resilience of BIPOC communities. And for us, this is such an example of supremacist ideas about who we are not, is that the fact that we're here is enough. Our existence is our resilience, especially given our existence is policed. Our behavior certainly, but for so many folks, for Black folks, for Indigenous folks in this country, the existence is policed. So we really sort of push back and sort of offer that resilience is actually our baseline. I mean, it's not a benchmark. We would also offer and urge for white folks, white institutions to think about what resilience means. And I think Dr. Cooper mentioned this about really needing to build resilience to resist the systems of supremacy, of power and protection that you are, you know, that you are beholden to, that there's a piece around who really needs to build their resilience. So those are the conditions and context of our work. I feel like I'm not going to go over these, but I do want to share as a public health organization, here's what we know. And certainly we are good at responding to kind of, you know, the ways in which we have to in our RFPs, our logic models. But we know that if we only respond to and meet the outcomes laid out by our systems and institutions, we are doing a disservice to our young people. We have to be bolder. And we have to do more than what is sort of given to us. And so here's where I want to offer, and I think again it's come up, is what we need in public health is really a liberatory way. We need to understand the political determinants of health. We need to actually, you know, move from confounding and regressing our data to like conflating and relating, that it should really reflect the messiness of our lives. And that when we're, you know, when we talk about collaboration, coordination, We know that the police and public health systems are actually more synchronous than siloed. We run a hospital-linked violence intervention program where we meet young people who've been lethally injured bedside. In our community, our trauma center is 25 miles from us. We are in Richmond, primarily Black and Latino. Our trauma center is in Walnut Creek, middle class and wealthy white folks. And so the staff reflect that too. So we get calls about our young Black members who are not behaving, who the staff there insist that their pain isn't real, who are just literally ignored by staff. We also know that the funding we get through some public health sort of systems is about, it's not actually about how are we supporting the young person in their recovery? How do they feel? What do they need? It's have we actually assessed for risk of retaliation? So there's already culpability put into the ways in which young people receive support, and that is completely racialized. And we also know that for any of our systems to support young people who are in that position, we have to have a police report number. Half the time, over half the time, young people aren't in a position to talk about what happened to a cop. So it is told that they were non-compliant, and so their victims of crime application is not approved. So we actually, as a staff, are prepared for the denials, and we have our appeal letter ready to go. And this is the way in which we have to contort to the ways in which sort of whiteness constrict us and devalue us. So we have to be real with what we know we're dealing with. But again, the setup is to both invisibilize us, but also to over-surveil us. And the last slide I have here before we open it up is, again, it's a lot of words, but we also knew as an organization, we really had to develop and articulate our framework around understanding violence, trauma, healing, and liberation, because we know all violence is state violence. We understand that, so even when I'm working with a young person who is needing to do, a restorative circle with another young person, we understand that harm has to be sort of addressed internally, interpersonally, but we also understand it's within a context. So you'll see on the left side, the dehumanization and distress, that trauma is atmospheric, it is historical, political, social, interpersonal, embodied. And these are the ways in which we understand it and have seen it. And this is an iterative document. As we learn, we shift it. But for us as an organization, then what our work is, it's on the right side. So then what does it mean to do liberatory and healing work? It can't be just, it is about what's my mindfulness practice, but if my mindfulness practice and what we push on young people is you need to be mindful to be able to continue to comply with systems and a world that doesn't give a shit about you, we are causing just as much harm. So maybe, I think that's the piece, like public health, I think needs to really grapple with the ways in which we police. And maybe, our supremacy comes with a hug or an incentive, but it still is about pathologizing and having to prove need and worthiness for supports versus having the systems needing to prove, apologize, amend, repair, and most likely also, really needing to be disrupted and dismantled. I'll stop there.
Thank you, Kanwarpal. Thank you to all of our panelists. I'm really full. Some of you have noted that you're full. People are chiming in the chat. Folks are teary, crying, emotional, inspired. So if we could just take a minute and take in the conversation. And in our remaining time, we do want to engage all of our panelists with a robust Q&A. We got a lot of questions even before the webinar, and then many more as you all were speaking. So I'm going to try to synthesize, summarize, pull some, but I want to remind folks that this is an ongoing dialogue. This is ongoing work. Healing and liberation is not linear, and so this continues after 2:30. You all hold a lot of space for community, for students, for mentees. You also are all really steeped in data. And I'm wondering, but also this came in the questions, how, if you're willing to share how you restore, replenish, as you hold up this heavy work.
I might offer a perspective. So I cry a lot and I breathe a lot. Some people call that meditation. I think it's important to allow these emotions to flow through you. I remember the first time I found some type of discrimination connection. I have asthma, and I found that some of these larger, these political economies of discrimination matter. And I fell on the floor and I just cried. And I have to think about that every time I run an analysis, every time I present. And this is not just other people's experiences, this is my own.
Yeah, say something. As Baldwin said, you know, to be Black in this country is to be angry. And I do the same thing. I cry a lot, but I'm also angry a lot. And one of the things that I'm angry about is what philosophers call epistemology of ignorance. The idea that certain people's knowledge is preferenced over other people's knowledge. And the idea that a woman who was raped and goes to court, her testimony is not as good as the man who says he didn't do it. But in this capacity, you know, I think just trying to do the right thing and to continue fighting, because it gets hard after a while. And what's so funny for me is that I've been on both sides, and I know what it was like to be a criminal. I know what it was like to be someone who was out there doing things that I'm not proud of now. But I also realized how much I didn't know. And I get angry when people deny me my lived experience and deny a group of people their lived experience. That's truly what makes me angry. And a lot of that comes out of an ideology of dehumanization, inferiorization, and degradation. Primo Levi said, he was in the concentration camp. He said, it wasn't enough for the Nazis to kill you. They had to dehumanize you. And dehumanization is necessary for many people to assuage their cognitive dissonance, many groups of people, and so the language that's used, one of the things I think we can do is define ourselves, to come to a point where we really don't accept the definitions of others about who we are. I have a friend I was talking to, he's working on his PhD, and he said to me day before yesterday actually, he said, "Oh, you're going on a panel? I'm tired of going on the panels. I don't want to talk to people who don't, you know, acknowledge my experience. I know what I'm talking about." He's working on his thesis on prostitutes during the Great Black prostitutes robbing white men during the Great Migration. So, and sometimes you get to that point when people say there's no such thing as systemic racism. It's only a few bad apples, but these few bad apples keep existing over long durations of time. So, you know, I think what you have to do is like kind of suck it up and say what you're fighting for is something bigger than yourself.
A lot of questions are asking around equity. So we talk a lot about equity in public health. We don't also always talk about justice when we talk about equity. But if the aim in public health is equity for all, what does that mean for groups of people that have been constantly tormented by these policies, by these practices that are meant to, quote unquote, serve us? What does radical change look like? What is reform? Is it reform? Is it abolition? What is real actionable change?
I can maybe start off to speak to this. I definitely feel like, I mean, especially now, everything's equity, equity, equity. Sometimes our systems will say a little bit about justice, kind of given the uprisings, but I feel like even saying that feels like too strident. We're still kind of facing that. But I think what I see and ambivalent around the equity tropes in public health is that there is still, equity still means being good middle-class white people. Like, equity is how can we all be that? And I still feel like that has not been sort of named explicitly. So I don't want to have equity in the same way, like it needs to be redistribution of risk, redistribution of resources, reparations. And so the measures and the frameworks we use around equity continue to be the same measures we use around like how we've been slicing and dicing Black and brown people's lives, and what's worthy to intervene and what's not. And so I would push us to think about, yeah, liberation, transformation as kind of the measures, and can we start to integrate those frameworks and what does it look like? So for us, it is, do young people feel loved? And we ask them, do you feel like RYSE loves you? We ask them, do you feel like RYSE staff love each other? And then it's like, do you feel like systems love you? And our work is to build systems that are loving. And loving means just, transformational, that hold all of us and all of our messiness and amazingness, but that also call out like what our histories have been. So it is not, it's not equality. So it's like, how do we even move beyond equity? Because I feel like equity is still about the stranglehold of white supremacy, whiteness as the center, the default.
Folks are asking about any organizations or organizers you want to lift up. Folks are wondering, who should they follow on social or read deeply in? Who should they donate to? What types of art should they make or buy or purchase to have behind them in all of our Zooms? Any folks you guys want to lift up? You got a lot of books behind you, David.
Yeah, I do. Oh, you said who do I read?
People are asking like who should they read? Who should they follow?
Oh, okay. That's no problem. I thought you was just talking about some groups out there. That well, I would start with Fanon and Du Bois. I mean, especially Fanon, because this is bigger than just what's going on in the United States. Fanon gave in Black Skin, White Mask, the analysis was brilliant. And he talked about this strange malady that he saw in the Black people, in the country he was in. And he considered it an existential malady that occurred after the imposition of imperialism and colonialism on that country. And I, one of the things I find that, well, Fanon, Du Bois, and just, I think maybe some science, and I think maybe anyone who can explain epigenetics kind of simply, because it's hard to do, But I think people have a problem with understanding distal causes and proximate causes. I've had this question for so long. When I was just talking about slavery and actually didn't know as much as I thought I knew about it, but I always felt that it had something to do with our existence, with the existence of Black folk in this country, that it had some impact on them. And people would whenever you bring up slavery, people always ask you, well, that happened so long ago. And they can't see a relationship between what happened long ago and what happens today. And I think if maybe we could do some work around connecting those relationships where people can actually understand them, because they're complicated. You know, there are behavioral effects, there are neurobiological effects. They're not just that easy to understand. But I think that if people would write books maybe for other people more rather than for academics, you know, one of my mentors in jail, you know, he didn't know he was a mentor, but there's a guy named Naeem Akbar who talked about trauma all the time, but never mentioned the word. Because he talked to Black churches and Black people. And he talked about how iconography affects you and how media affects you. And I think we need more people who speak on that level so that people can understand.
And if I could take moderator privilege, I just want to lift up one text, the Combahee River Collective statement, written in 1977. Many of the writers are still with us, right? Not ancestors, living archives. I assign that in my classes, whether I'm teaching high school students, college, undergrad, folks who are not students, really centering Black feminism's intersectionality, centering lay knowledge as well as academic texts, and really a movement, some people call it a sacred text, right, for thinking about liberation and justice and healing.
I might add two people. So W.E.B. Du Bois, really kind of preeminent scholar. The two books I would think about is his Understanding of Black Reconstruction. It's a great book on the transatlantic slave trade, essentially, and the construction of Black civil institutions, as well as I would look at Souls as a set of essays, but it gets into this idea of the double consciousness and the ways in which we can organize ourselves within this kind of outside or within space. Speaking of that, I would definitely think about Patricia Hill Collins' Black Feminist Thought. It kind of gets into it a lot good. And then just two more people, but Dorothy Roberts on the issue of the entire construction of race and the ways in which it's been politicized, not just in our legal system, but in medicine, in science. And we cannot have a conversation about the use of race as a biological or essential understandings of criminality without understanding the essential ways in which the concept of race was constructed in the first place. And medicine and science are the backbones of that. And the last one, if you are on that range, but I would look at Black Marxist test. The one I think about the best is Cedric Robinson's text. And I think along the line of the Fanon, Manning Marable, along the lines of those individuals thinking about discrimination as a system. You're right as far as thinking of this. People don't really understand systemic effects. They know it's there. It's like it's in the air, it's the water, it's the thing we breathe. And there's a difference between measuring it, the difference between feeling it, and a difference between understanding the ways in which this systemic racism actually sets the entire set of assumptions under which all of our social and political relationships are activated.
And I just, I know we're running short on time, but I just want to, I can't see the people in the audience, so I don't know who's here, but I want to take a moment to talk to the people in the audience who identify as white and just, talk for a moment about resources around learning about and surfacing whiteness. I think that's really, really vital. And so for me, I've looked to David Roediger and some of his colleagues on the construction of whiteness. I've read, one of the first books that I read that kind of took me down this path was, the first book was Manliness and Civilization, which is very much about the construction of whiteness in the British Empire. And Edward Ball is someone who has written about being a descendant of people who have enslaved other people. It's a very powerful book. And so if you're like me and you are trying to come to terms with being a product of crimes against humanity, I think Edward Ball is a really useful person. And if you want to get involved in some groups, there's something called Coming to the Table, which is designed for people like me who are the descendants of people who enslaved others. And it's just, I think, an important resource.
We have just a couple minutes. We have a lot of students on the call. We are a school. Many of you are teachers, mentors, guides. And so students are asking how they can continue to contribute to the combating of state-sanctioned violence, how they can be active from the streets to the classroom to other spaces, virtual spaces, right? Thoughts on that?
You know,
Go ahead,
sorry,
Dr.
please go ahead. Go ahead.
Well, I can offer something I share when I have the privilege to be able to be teaching is usually the first few classes are really about how do we build beloved community, and to sort of really set the stage to understand that our success in academia is not our liberation. We have to separate those things. And so what is the role of academia and us being here together in our liberation? So what I'll say is, you know, what do you really want to do? How do you focus on that? What do you need to let go of? So for me, for an example I'll give is when I was in grad school, I was like, this is the piece I want to do. I got to work full time. I got all these other stressors and dramas going on. If I get a C in this class, I get a C, but it's because you know what? It's about me. And if it's about me in bigger movement work and legacy work. So also I try to sort of, how do we really separate, our success in the schooling from the liberation of our people? And what's the role and responsibility?
Dr. Sewell, you were going to say something? Maybe last words?
Oh, yeah. So, you know, the thing I think about the most is people often dismiss the social media aspects of this. I think this is a generation and a time where you can't do that. And maybe we can have a debate about what is activism and not activism, but any type of participation is a form of activism. And the reason I think that's really important is when Mike Brown died and he laid on the floor for these minutes, it was Black Twitter that brought awareness to what these things were. There was no media coverage of this. And it's like this for a lot of things. There was no video of Eric Garner. Where would we be if there was no video of George Floyd? Would we have seen these protests? So we have to take this simple as the simple thing of turning on the camera, turning on the record function, sending a tweet can bring awareness to something that people have taken for granted, either that, oh, it happens all the time, why put attention to this one? Or on the other hand, bringing things to the light that the establishment is very interested in ignoring and silencing.
Thank you for that. Thank you all for your expertise, your graciousness, your vulnerability. Thank you for those of you that are Zooming in. Again, this recording will be made available. On behalf of all of us at NYU School of Global Public Health, we appreciate your engagement. Please make sure that you register to vote one way that folks can contribute, and cast your ballots safely on November 3rd. May everyone take care and be well.